Hello, my name is Sean Adibi and I'm an associate professor of University of Texas School of Dentistry at Houston. This module is prepared for you in collaboration with Dr. Boko from its original form known as Adibi Rays. Please see a brief biography of Dr. Boko and I presented here for you. Please read the disclaimer for the following continuing education presentations. Neither the authors or immediate family members of this presentation receive any financial benefit from commercial entities that may be relevant to this presentation or have any conflict of interest. All materials presented here are with independent judgment of presenters with regard to the content of it. You may take as many breaks as needed during viewing this video streaming. Simply pause the video and return when you are ready. When viewed the entire presentation, you will be notified to take a brief examination to meet satisfactory requirement of this video course. The presentation is combined of case studies and provides information in X-ray and is shown step by step, including diagnosis, treatment planning, and final outcome. This module presents radiologic interest lesion presented to practitioners that requires identification of these common lesions of interest, necessitate creations of a differential diagnosis, and develop a management plan. Upon completion of this course or module, the participant should be able to identify common lesions of radiologic interest, create differential diagnosis for select radiographic lesions, develop an appropriate management plan for select radiographic lesions, evaluate what's learned in this module. Select cases 1 through 6 consist of an expansile multilocular radiolucency region, an unexplained vertical loss of the crestal bone, an apical radiolucency with vital pulp, and non-expansile multilocular radiolucency, and unilateral radiolucency around crown, and a furcation radiolucency with painful tooth. Selected case 7 through 12 consist of a moth-eaten, painful radiolucency, a rounded radiolucency in tooth overlapping the pulpal canal, an apical radiolucency with non-vital tooth, a unilocular cervical radiolucency, condylar radiolucency with sclerotic rimming selected here. Selected cases 13 through 18 consist of a unilocular radiolucency with sclerotic rimming, a heart-shaped radiolucency as root-shaped radiolucency, a well-demarcated radiolucency at the inferior border, a poorly organized multilocular radiolucency, and a radiolucency with destruction of inferior border of mandible. This case is a 35-year-old male with painless lesion on the anterior section of a mandible with clear demarcations and multilocular with the area of a thin border sclerosis. Cortex is expanded to the facial and teeth have been tipped and moved. Which diagnosis is the best based on given information? Central hemangioma, aneurysmal bone cyst, traumatic bone cyst, odontogenic keratocyst, ameloblastoma, and central giant cell granuloma. Ameloblastoma is the best choice here. Biopsy is a must here to confirm diagnosis. Aspiration before biopsy is necessary to rule out possibility of vascular lesions. Excision should include about 2 mm of the surrounding normal bone tissue. Follow-ups for these type of lesions in 6 and 12 and 18 months, and annual recall thereafter is recommended. Key diagnostic points to select ameloblastoma on this case was the sharp border with sclerotic rimming, being multilocular with differing size in soap bubble appearances, expansion to facial plane, and with patient of being of a middle age. This case is a 44 years old male with a mandibular molar of asymptomatic with no gingival erythema, but a vertical loss of a crestal bone down to the mid-root level that appeared to be only isolated to this area of the mouth. Which diagnosis fit the best on this scenario? Is it localized aggressive periodontitis? Is it eosinophilic granuloma, a papillon-lefèvre syndrome, diabetes mellitus, leukemic gingivitis? Is it segmental tear, buccal bifurcation cysts? This is eosinophilic granuloma, or also known as Langerhans cell histocytosis. Biopsy is necessary to confirm diagnosis. Excision should be wide enough to include all involved area. Patients should be referred to see internal medicine physician for whole body evaluation for possibility of similar lesion using technetum 99 bone scan. The key diagnostic feature on this case was the unexplained localized crystal bone loss without other associated periodontal or gingival condition. This case involves a 48 years old female of African American origin with asymptomatic mandibular periapical radiolucencies. Which of the following works to be the best diagnosis? Periapical granulomas or cysts, periapical cemento-osseous segmental tear, vitamin D resistant rickets, cementoblastomas. Periapical cemento-osseous dysplasia or florid cemento-osseous dysplasia is the diagnosis. This condition needs no treatment as long as asymptomatic and no infection involved. It usually does not harm teeth. Often, the more mature types of this condition have some central calcifications within the radiolucency in periapical areas. This is a 33 years old female with a well-demarcated multilocular soap-bubbled radiolucency with a thin, uniform sclerotic rimming with very little cortical expansions of the ramus of a mandible. Which diagnosis would be the best one? Is it an ameloblastoma fibroma, ameloblastoma, odontogenic myxoma, odontogenic keratocyst, central ossifying fibroma, aneurysmal bone cyst, or traumatic bone cyst? This is an odontogenic keratocyst. Obviously, this must be biopsied after aspirations to rule out vascular tumors. About 1.5 centimeter of the radiographic margin should be removed. It should be noted that this condition can proliferate slowly if embedded in soft tissue at surgery time. Key diagnostic feature here is lack of cortical expansions around a large multilocular radiolucency with very thin borders. This case is a unilocular radiolucent lesion around a crown of a tooth in a 28-year-old female that is asymptomatic in an impacted third molar area. Which diagnosis is best for this lesion? Is it dentigerous cyst, ameloblastoma, odontogenic keratocyst, residual cyst, or a traumatic cyst? This is a dentigerous cyst. The best approach is to curettage or enucleate it with extractions of associated tooth to biopsy. Follow-up of 6 and 12 months is necessary for these conditions. Key diagnostic feature of this case is the lesion with respect to the cervical area of the crown of the tooth involved. Its unilocular appearance, as many benign odontogenic neoplasms are. This case is a 35-year-old male with mandibular molar tender to percussion with a poor demarcated radiolucence between the roots, along with the history of endodontic therapy of the tooth. Which diagnosis fit best to this scenario? Buccal bifurcation cyst, fractured tooth with furcation infection, acute osteomyelitis, cemental tear, or periodontitis with furcation defect. This is a fractured tooth with furcation infections. The tooth is most likely hopeless, other than possibility of hemicectomy and complex restorations. In any cases, it may be necessary to curette the extracted socket with addition of antibiotic coverage if pain persisted. Key diagnostic feature for this case was the line immediately beneath the pulp chamber with poor demarcations of the border of the lesion, the thickness of the periodontal ligament at the distal root with the destruction of lamina dura in furca. This is a 48-year-old male, tender alveolus of the left anterior maxilla with irregular radiolucency of a moth-eaten appearance and crystal perforations and draining pus. Which diagnosis fit this scenario? Periapical abscess or fistula, suppurative acute osteomyelitis, chronic non-suppurative osteomyelitis, carcinoma invading alveolus, osteosarcoma, or residual socket. Suppurative acute osteomyelitis is the right diagnosis for this patient. This patient may need long-term antibiotic coverage after curettage of involved bone. Radiographic examination, follow-up of 6, 12, and 18 months is necessary for this condition. Key diagnostic features are the draining pus, moth-eaten border of the lesion, and pain. This case is about a 40-year-old female patient with a circular radiolucency superimposed on a tender maxillary incisor root. Which diagnosis is best for this case? Is it central ossifying fibroma, benign odontogenic tumor, lateral periodontal cyst, lateral radicular granuloma, external root resorptions, and cracked tooth syndrome. The diagnosis is external root resorption. Determination of a location of the defect is necessary first. It may be in lingual or facial aspect. It can be determined by either multiple radiographs in varied angle or cone beam computer tomography. When external resorption of a root diagnosed, it can be curetaged with care, avoiding pulp involvement. Follow up at 6 months. If lesion enlarged in size, tooth must be extracted. Key diagnostic signs for these lesions are that pulp canal outline remained intact. If pulp is irregular in shape, the diagnosis is internal and external root resorption. This is a 30-year-old female patient with moderately well-demarcated non-expansile radiolucency at the periapical area with non-vital teeth. Which diagnosis is best? Central giant cell granuloma, periapical cementoosseous dysplasia, periapical cyst, periapical granuloma or apical periodontitis, periapical abscess, or cementoblastoma. Periapical granuloma or apical periodontitis with radiographical evidence of external root resorption is the probable diagnosis for this case. The best way to manage this case is either endodontic therapy or extractions. If during extraction bone cavity present, curettage is necessary to remove diseased tissue. Key diagnostic signs for this case were the location of the lesions on apex of the non-vital teeth with external root resorption suggesting the inflammatory conditions of lesion. The scalloping features of the distal aspect of the lesion rules out the periapical cyst. This patient is 22 years old male with a well-demarcated, small, asymptomatic, unilocular, radiolucent lesion distal to the mandibular third molar and immediately adjacent to the tooth at the cervical region. What is the diagnosis for this condition? Pericoronitis, dentigerous cyst, lateral radicular granuloma, or laterally located periapical cyst, benign odontogenic tumor, or chronic osteomyelitis. This is a dentigerous cyst and a lateral type. Often it is possible to remove the radiolucent portion of the lesion without extracting the tooth. In that case, it would be necessary to follow up with a 12-month radiographic examination to assure lack of recurrent lesion. Diagnostic key to this case were the location of lesion to cemento-enamel junctions of the tooth and the small size of it. Sometimes it may locate on both mesial and distal aspect of the tooth. And then we'll call them circumferential type. This case is a 27-year-old male with an irregular outline radiolucency of a central maxillary incisal that superimposes over a partially obliterated pulp canal. Which is the best diagnosis for this case? Pulp polyp or hyperplastic pulpitis, external root resorption, internal and external root resorption, sarcoma, destructions of tooth. Diagnosis is internal and external root resorption. Most of the time, endodontic therapy fails on a case like this one. It is important to treat the condition quickly because the inflammatory condition may extend and affect adjacent tooth. Key diagnostic feature on this case are the irregular appearances of radiolucence area with outline of the pulp canal partially destroyed by inflammatory process, regardless of existence of pain. This is a case of a 55-year-old female with irregularly outlined, tender radiolucency of a thick sclerotic rimming with subcortical increased radiolucency and loss of density of cortex in the right condyle. Which is the best diagnosis for this patient? Is it condylar concavity, subchondral cyst, ischemic osteonecrosis, or central ossifying fibroma? This is an ischemic osteonecrosis with cortical destruction. Usually no treatment needed, unless it becomes unbearably painful. In that case, intervention may be necessary to cure it surgically. In more severe cases, removal of condyle or condylectomy is done. Referral to orthopedic surgeon may be necessary to evaluate osteonecrosis of a hip or knee. Key diagnostic feature on this case were pain, irregular radiolucency of outlines of the lesions with thick sclerotic periphery and subcortical region of increased radiolucency. This is a 50-year-old female with poorly demarcated, faintly gray radiolucency, non-expansile, moderately painful mandibular third molar region with extractions done several years ago. Which is the best diagnosis? Intramedullary fibrous scar, focal osteoporotic marrow defect, benign odontogenic tumor, residual cyst, metastatic carcinoma, primary sarcoma, chronic osteomyelitis. Diagnosis is intermedullary fibrous scar with small residual flecks of endodontic paste and possibly poorly healing extraction sockets. No treatment needed except to reduce pain. It must be biopsied to rule out carcinoma, sarcoma, or osteomyelitis. Usually do not increase in size over the time and they do not perforate cortex, but may expand slightly. Key diagnostic features on this case are focal osteoporotic regions and poor outline with demarcated borders. This case is about a 39-year-old male present with asymptomatic, heart-shaped, non-expansile, well-demarcated radiolucency of the anterior midline of the maxilla. Which is the best diagnosis? Periapical cyst, periapical granulomas or apical periodontitis, odontogenic keratocyst, nasopalatine duct cyst, benign odontogenic tumor, or traumatic bone cyst. Diagnosis is nasopalatine duct cyst. This condition should be referred to an oral surgeon for removal of the cyst from palatal side. Patients should be informed that there is a risk of sensory loss after surgery. However, if lesion is not removed, it may become very large and destructive to adjacent structures. Key diagnostic features in this case is the location of the lesion in middle of the anterior sections of palate, heart-shaped or rounded appearance of the lesion that superimposes the nasal spine. This is a case of 51-year-old female patient with a well-demarcated root-shaped radiolucency beneath a pontic remains 12 years after bridge is made. Which one is the best diagnosis? Chronic osteomyelitis, residual socket or ghost socket, intraoral fistula, subpontic osteonecrosis, or residual cyst. Diagnosis is residual socket or ghost socket. No treatment needed unless it becomes painful. When treatment needed, do curate the radiolucency. It is known to form due to local ischemia or low-grade inflammation at the time of extractions. No follow-up radiograph needed. The lesion may fill with either fibrous scar tissue or maybe a hollow space void. Key diagnosis points on this case were root-shaped radiolucency under the pontic in edentulous area with history of extraction that may or may not be painful. This case is about a 49-year-old male patient with a well-demarcated oval shape, asymptomatic radiolucency at the inferior border of the mandible with a sclerotic rimming. Which diagnosis is the best one? Osteoma, sinusoid cyst or sinus mucosal, buccal exostosis, anterolith, palatal torus, or cementoblastoma. Diagnosis is Staphney defect or Staphney cyst. Usually, cone beam computer tomography needed to confirm diagnosis on concavity located in lingual aspect of a mandible to rule out central lesions. Once it is confirmed, no biopsy or treatment is needed. These lesions may enlarge in size over the time, but no radiographic follow-up is necessary. Key diagnosis feature on this case were the location of inferior alveolar being just above or at superimposed over the mandible, in addition to appearance of no concavity with inferior alveolar canal with no symptom or expansion evident. This case is a 46-year-old female patient with painful, poorly demarcated, oval shape, osteoporotic, radiolucency presents bilaterally in third molar area of the mandible. Which diagnosis is correct one? Hyperparathyroidism, bone marrow edema, or chronic ischemic bone disease, chronic non-suppurative osteomyelitis, bilateral odontogenic tumors, traumatic bone cyst, florid cementoosseous dysplasia at its early stage. This is a bone marrow edema or a chronic ischemic bone disease. Conservative curettage is solution to this condition. Follow-up radiographs in 6 and 12 months and referral to hematology for evaluation of hypercoagulation states with possibility of 2% of the patients having this condition. Key diagnostic features are poorly visualized radiographic patterns that are bilaterally in nature with no evidence of expansion or perforations to cortex along with severe pain. This case is a 39-year-old female patient with moderately well-demarcated radiolucency that has some irregular outline lacking any sclerotic border. Which diagnosis is the best? Acute osteomyelitis, chronic non-suppurative osteomyelitis, metastatic carcinoma, sarcoma of the bone, primary lymphoma of bone, Staphney defect cyst, or periapical granuloma cyst. Primary lymphoma of the bone is diagnosis. Biopsy is needed before treatment, referral to oral surgeon for biopsy, and oncologist after confirmation of diagnosis to evaluate possibility of metastasis. CBCT and/or MRI will be needed for evaluation and treatment that will include radical resections and chemotherapy. Key diagnostic features are irregular outline with no sharp margins, located in mandible, periapical to teeth, and with no relations to them. Please see listed references for the presentation. This completes the Module 1, Radiolucent lesions. It is time for you to take a short exam in order to complete the requirement for this video course. Due to the nature of this subject matter, passing a score of 80% is necessary in order to receive credit in this course. After completion of the examination, you will receive a visual confirmation of successful completion. If you fail to answer enough questions correctly, you will be instructed to take the exam and new set of a question will be provided. You will have 3 chances to satisfy this requirement. If you are not successful, you will be instructed to review this module again before your next attempt. Your exam is next. Good luck with your exam if you are ready to take it.